Hello, everyone. Dr. Alex Vasquez here. Today, continuing our conversation on this clinical review of vitamin D deficiency in adults. This is part 4 on inflammation, coagulation, and immunomodulation, which might also be subtitled Looking for Signal Among Noise, Deepening Our Understanding from 2004 to 2021. The 4 main conversations in today's review will include some background and considerations. For example, I'm going to talk about hypercoagulation, but I'm sure that most people probably haven't studied hypercoagulation, so we at least need to have some orientation to that topic. After that, we'll look at some rejected data, some data that's really not worth our consideration, but I'll show you why it's not worth our consideration. And then we will move on to the main course of 23 clinical trials, plus excerpts and reviews, and we'll look at data from several thousand patients. I'm just guessing it probably includes about 15,000 patients. And then I'll provide a summary and closure. So whenever you see this mauve background, that means that we are transitioning from one of these groupings into the next. Let's start by looking at a few quiz questions that might help us kind of get oriented to the level of competence that we might aspire to. So for example, we might ask, like, what are the best ways to administer vitamin D for the prevention of chronic illness versus acute illness? We might look at some parameters, and we might review some of the information that I already talked about in videos 1, 2, and 3. For example, information specific to chronic pain and pain amplification, as well as anxiety, depression, and neuroinflammation, as well as barrier defenses. Also, the interpretation of lab tests, of course, is very important, so I emphasize that here in question number 11. And of course, anytime you want to pause the video and kind of deepen your understanding of the information, you're certainly welcome and indeed invited to do that. I would like to be able to present this information to you, but if I take the time to read and explain everything word for word, then of course that would turn a long video into an all-day presentation, and we certainly can't afford that time in this setting. So what I would invite you to do is anytime you're interested in learning more, just pause the video, read things word for word, think about it, and then that will help you deepen your understanding without me having to kind of go through the nuances of those conversations within today's video setting, which again, let's assume that I can do this within 1 hour. If I explained everything word for word, that would probably take us at least to 4 hours. So I'll invite you to kind of achieve the level of study that you're comfortable with. As I'm sure you know, we've been looking at this vitamin D and inflammation and disease treatment and prevention model now for at least 17 years. And over the course of that 17 years, we would naturally expect things to kind of mature and develop. So the answers that we had back in 2004, pretty much by definition, need to be different from those answers that we might have now by taking a fresh look at the information. And indeed, that's the case. I think our overall conclusion will probably be the same, but we'll have more nuance and a deeper appreciation of the advantages and disadvantages and limits and the clinical applications of this information. So I invite you to stay tuned as we walk our way through this information. I'm going to focus here on citations just to give you, of course, the source of the information. We'll look at what they actually did, and then we will see what test results actually changed. So in most of the studies, we're looking at inflammatory markers and how those changed in response to what we hope is competent vitamin D supplementation. And sometimes they did or didn't look at clinical effects. A lot of times these studies were just looking at inflammatory markers. Sometimes we have clinical effects without the inflammatory markers, and more often the reverse. So we'll try to put that into context, and then we'll try to put that into a larger context of all of the information and kind of look for patterns so that we can appreciate what's going on overall and what we can expect when we're working with actual patients or conducting research. In preparation for today's presentation, I reviewed a large amount of information, and whenever I have to organize a large amount of information, I try to give it a structure, even if it's just a simple acronym to help me stay organized. And the one that I eventually settled on was CITES, which is Citation, Intervention, Tests, Clinical Effect, and then the summary. So that's the structure that I will use as I review today's information. So I had hoped that over the intervening 17 years since we published the vitamin D monograph in 2004, I had hoped that the evidence would be very clear and actually a bit simplistic, if I must say, because I was looking for basically a continuation of this level of research, which was published back in 2002 in Quarterly Journal of Medicine, showing that vitamin D supplementation could actually alleviate this subclinical excess inflammation. This was actually a beautiful and elegant study But by today's standards, we might question some of the ways that this study was designed, implemented, and measured. For example, the dose of vitamin D that they actually used was very low, and therefore the serum response was very low. And even though this data supports the general idea that vitamin D has an anti-inflammatory effect, it's certainly not consistent with what we would consider good practice in clinical nutrition these days. So we'll look at the study again later, but I wanted to show you this example of what the data looked like earlier versus what the data looks like now. And I think these days we actually have more robust data to extend this into a better understanding of how vitamin D functions, and also how to explain some of the inconsistent results that we see with very low levels of vitamin D administered to patients who are very vitamin D deficient. And again, I'll talk about the details later when we look at this study again. One of the things they found in this study of very deficient patients who were given low doses of vitamin D is that their fibrinogen levels actually increased slightly. And I'll be happy to provide you an explanation for why I think that happens. And I think it has to do with stimulating generalized protein synthesis in these patients who are severely vitamin D deficient. And I'll explain that more with some diagrams in just a few moments. As I've said from the start of this series on vitamin D deficiency in adults, I really think that vitamin D deficiency in adults needs to be redefined now, because many of us who grew up reading Robbins' Pathologic Basis of Disease were only taught that vitamin D deficiency in adults presents as osteomalacia, which first of all, most doctors don't know how to diagnose clinically, and second of all, that really misses the grand picture of the complications that result from vitamin D deficiency. So I've already talked about chronic pain and pain amplification. We've also talked about mood disorders, depression, and anxiety. In part number 3, I talked about impaired barrier defense, which increases the risk for infections, and also autoimmune conditions and allergic conditions. And right now we're talking about inflammation. So we need to get away from the idea that vitamin D deficiency in adults only presents as osteomalacia. We're going to see that the consequences are much grander than that and much more common than that. And that's yet another reason why vitamin D deficiency needs to be treated instead of just assumed, I guess, to be somewhat normal, because it's not normal. And I think this underscores the urgency for treating vitamin D deficiency in the prevention of pain, mood disorders, impaired barriers and infections, and disorders of excess inflammation. So let's say that a patient acquires a viral infection due to number 3, impaired barriers here. And because of their impaired barriers, they're more vulnerable to the infection. And then when they get the infection, they have more inflammation and less modulation or control of that inflammation. So they're more likely to enter into a virus-induced cytokine storm, which can have fatal consequences, including acute lung injury and acute respiratory distress syndrome. So in those situations, are we going to blame an otherwise benign virus, or should we look farther upstream to the nutritional deficiencies that led to the vulnerability to that otherwise benign viral infection? I think the data is very clear that we need to be looking upstream to the nutritional deficiencies that make some people vulnerable to what would be otherwise a benign viral event. So again, today's focus is going to be mostly on inflammation, but anytime we talk about inflammation, we also have to talk about coagulation. And whenever we talk about inflammation and immune function and barriers and coagulation, we then end up talking about cellular defense, barrier defense, what I call here protein defense, which includes antibodies and antimicrobial peptides. But of course, we have to balance that conversation by looking at immunomodulation and immune tolerance. Anytime we look at all those together, we end up talking about the microbiome. We also talk about metabolism and mitochondria, both of which are influenced by vitamin D and, of course, other nutrients and dietary patterns. We talk about nutrients working synergistically together, but nutritional deficiencies also function synergistically to promote negative outcomes. So, for example, let's say that 60% of people worldwide are deficient in vitamin D, 30% are deficient in zinc, and 15% are deficient in selenium. What happens to those people who are deficient in zinc, selenium, and vitamin D? Obviously, they're going to be more vulnerable to otherwise benign infections, especially viral infections. And that's an example of where we could really have a public health and global health impact through the use of safe, affordable, and readily available nutritional supplementation. Again, when we talk about vitamin D supplementation, we can also talk about neuroinflammation of the hypothalamus, neuroglia, and the effect that that has on the vagus nerve and overall metabolism and inflammatory balances. We can talk about hormones, cytokines, and neurotransmitters. And we can appreciate that nutritional status has a bidirectional relationship with psychosocial events. So, for example, when people are nutritionally deficient, they're more likely to have depression, anxiety, and other mood disorders. So that affects their psychosocial interaction, and the psychosocial and political climate that we live in also determines our nutritional status through food availability and either accurate news or what we might call fake news within nutrition and medical news, which all too commonly discourages people from pursuing appropriate nutritional supplementation. The relationship between psychosocial influences and nutritional status is, of course, bidirectional, because when people are nutritionally deficient, they're more likely to have mood disorders such as anxiety, depression, and aggression. And depending on the psychosocial and political climate that we live in, people might be encouraged to eat junk food, or they might be discouraged from using nutritional supplements. And of course, then that creates a vicious cycle for negative psychosocial impact. And of course, all the while, we are living in a toxic environment loaded with metals and xenobiotic chemicals. So again, I'm going to focus today on inflammation, coagulation, and maintenance of immune tolerance via what I call nutritional immunomodulation, which is one of the protocols in my book, Inflammation Mastery. I think that overall we've given too much attention to inflammation and not enough attention to barriers and immunotolerance. So today we're going to balance out that conversation a bit, and we're going to focus on not simply inflammatory markers, but also anti-inflammatory markers, and how we can change immune phenotype through the use of nutritional supplementation. And again, I discussed that in Chapter 4 of Inflammation Mastery 4th edition, and that's what I call the Nutritional Immunomodulation Protocol, and I'll show you a few excerpts and diagrams from that section later in today's presentation. On the following page, I provide a quick list of the inflammatory markers that we consider most commonly. These are CRP, interleukin-6, interleukin-1, tumor necrosis factor alpha, fibrinogen, and interleukin-10, which is the uniquely anti-inflammatory cytokine. We all know about the common causes of inflammation, and we're not expecting vitamin D to perform as some miracle anti-inflammatory agent. So, for example, if a patient is obese and they continue smoking, then of course they're going to have ongoing problems with inflammatory complications. But even in those situations, vitamin D may provide some amelioration of their excessive inflammatory response. So what we're trying to do is address the vitamin D component and perhaps also the microbiome component of their inflammation by using vitamin D supplementation if they are deficient in the context of having excess inflammation. Excess inflammation couples with excess coagulation for reasons that I explain on this page. But again, we're not expecting vitamin D to function as an anticoagulant. What we're trying to do is normalize situations of excess inflammation attributed to vitamin D deficiency and its consequences, such as obesity and gastrointestinal dysbiosis, both of which are influenced by vitamin D status. Here you can read a few more ideas if you want more details, but let's look at some of the risk factors for thrombosis, deep vein thrombosis, pulmonary embolism, and venous thromboembolism. Many of the risk factors for thrombotic complications are genetic, so we often consider factor V Leiden mutation, hyperhomocystinemia and homocystinuria, prothrombin mutation, and also anticardiolipin and antiphospholipid antibodies, which are seen in various autoimmune conditions. So again, this is a listing of some of the major risk factors for thrombosis and venous thromboembolism. We're not expecting these to be alleviated by vitamin D supplementation. On this page, I list some of the laboratory and analytic considerations when assessing inflammatory balance. Prior to developing this particular presentation, I was already starting to develop the impression that vitamin D deficiency, especially more severe vitamin D deficiency, could induce a state of anti-anabolism or catabolism. And I think the best example of this is when we look at elderly patients with vitamin D deficiency who have sarcopenia and also cognitive decline, which can be interpreted both as measures of impaired protein synthesis. And I think that might explain why we see a slight increase in fibrinogen levels when people are severely deficient and they're only partially repleted with vitamin D. So, for example, as I show here, what we see in patients who are severely vitamin D deficient, when they are given vitamin D, their fibrinogen levels actually increase slightly. And I'm proposing that that might be due to the initiation of global protein synthesis, not necessarily a pathologic response, but just that their bodies are actually able to function again now that they're a little more nutritionally replete. So again, what I'm referring to specifically here are the two studies that show that in patients who are very vitamin D deficient, giving them vitamin D actually causes a slight bump in their fibrinogen levels, a slight bump upwards, and then things normalize later. which again is why we have to look at the overall pattern of the research and the overall pattern of the clinical effects, not just look at these outlier studies where they use very low dose in patients who are very vitamin D deficient. So again, transitioning patients from an anergic and catabolic state into normal physiology appears to induce a slight increase in their fibrinogen production, at least at the start of nutritional repletion. Very quickly here, I'll talk about the vicious cycle of vitamin D deficiency, and that is when people are vitamin D deficient, that puts them at higher risk for inflammatory and infectious diseases. When they develop those inflammatory and infectious diseases, that actually depletes them of vitamin D, and that creates a vicious cycle. So I think this is what we see with vitamin D, and for sure this is what we see with vitamin A. So the vicious cycle is actually more established with vitamin A than it is with vitamin D, but I think it applies to both. Nutrient deficiency predisposes to infection and excess inflammation. Then those infections and excess inflammation actually cause nutrient depletion, and that exacerbates the original nutritional deficiency. So again, this is the vicious cycle of nutrient deficiency, predisposing to disease. Then the initiation and development of that disease actually causes more nutritional depletion, which makes them vulnerable again. And as I mentioned previously, we also see this with zinc and protein deficiency. So again, nutritional deficiency leads to vulnerability. Vulnerability leads to infection and inflammation. Infection and inflammation further depletes nutritional status, and that leaves people in a worse situation than when they started because now they are more nutritionally depleted, and that creates this vicious cycle of zinc and protein deficiency, also vitamin A deficiency, and I believe also vitamin D deficiency. Let's take one more look at this concept here when I talk about crisis-induced depletion of vitamin A. So when people are acutely ill, especially with an inflammatory condition such as an infection, like a viral infection, the classic example, of course, being measles, when they become acutely ill, they actually lose vitamin A due to changes in renal handling and protein metabolism. That leads to epithelial failure in the respiratory tract as well as in the gastrointestinal tract, and that vitamin A depletion then leaves them vulnerable to ongoing or recurrent infections as well as inflammatory complications of those infections, because when they lose vitamin A, they also lose the ability to generate those modulating or anti-inflammatory T regulatory cells, and so this becomes a vicious cycle of one crisis after another. And I'm quite sure that this explains some cases where patients get ill and have a hard time getting out of that vicious cycle until they are nutritionally repleted. And not only with vitamin A, but also with vitamin D, zinc, protein, cysteine, and other nutrients. Very quickly here, before we get into the main course, I'll show you 4 studies that I rejected, and I will show you why I rejected them. This study used a very unusual type of vitamin D. Even though they called it vitamin D3, it was actually 1-alpha hydroxyvitamin D. That's not clinically available, and it's certainly not the clinical standard of use. This study was absolutely ridiculous. They used a bolus dose of ergocalciferol, which is absolutely horrible, and then they concluded that vitamin D didn't raise vitamin D levels. I think that that's completely absurd. The following study also used bolus dosing, and they really didn't show much of a deficiency-sufficiency differential, and so their results were not very robust. They did not look at inflammatory markers, but they did show a slight improvement in glycemic tolerance. And the final study here that I rejected is simply an observational study. It's not a clinical trial. What they showed here is that neonates with vitamin D deficiency have more inflammation as measured by C-reactive protein. But again, this wasn't an interventional trial, so it doesn't really tell us much about the causal relationship between those two variables. It just shows us that vitamin D associates with more inflammation, but it doesn't tell us why, and it really doesn't inform clinical practice. So now I'm going to focus on the 23 clinical trials and reviews that do enlighten clinical practice. All of these, again, are clinical trials in humans using hopefully at least reasonable doses of vitamin D, and I'll explain that as we go through. And we'll look at data from several thousand patients. We're going to start with this first article from 2002 that I mentioned previously. This was published in the Quarterly Journal of Medicine, and what they did here is give kind of a low dose of vitamin D. They gave an intramuscular injection of 50,000 international units once every 3 months. So that comes out to about 500 international units per day, which of course is not consistent with good clinical practice these days. But nevertheless, what they showed here is a 68% reduction in MMP9, which is an inflammatory marker and an inflammatory mediator as well. Also a 23% reduction in C-reactive protein. This marker here, TIMP1, is actually kind of an anti-inflammatory kind of counter-regulatory marker. So even though it's anti-inflammatory, it did reduce, but it reduced because these other markers were modulated with the vitamin D. What they showed here is what I mentioned previously. They showed a slight increase in fibrinogen, and for me that was unexpected, but I think it could be explained by the initiation of protein synthesis by taking these patients from being horribly deficient to actually less horribly deficient. So they were very low at 8 nanograms per milliliter. With treatment, they came up to 14 nanograms per milliliter, which is still horribly deficient. The authors here did not look at any clinical effects, so my summary of this study is vitamin D supplementation, even very weak supplementation, reduces markers of inflammation, MMP9, TIMP1, and C-reactive protein, with a paradoxical slight increase in fibrinogen, no measurement of interleukin-10. The dose of vitamin D in this study was minuscule and certainly not consistent with modern clinical practice, although it was appropriate for the pre-2004 era. So again, this was published in 2002, which means they collected the data prior to that. I actually think they had a 5-year follow-up in one part of the study here, which means they would have started the study at least in 1996, maybe 1997. So for that era, this was a very appropriate study, even though, again, it wouldn't be consistent with clinical practice these days. Nonetheless, we do see clear evidence of anti-inflammatory benefit by seeing reduction in all of these inflammatory markers. Let's look at a more modern study here. This is from American Journal of Clinical Nutrition, 2006, so a little bit more advanced in terms of getting over the threshold that we crossed starting in 1999 with Veith's article, and then the Zitterman article in 2003, and the Robert Heaney article in 2003 as well, and then my article in 2004. So here we are now, 2006. In this study, they gave approximately 100 patients 2,000 international units of vitamin D, and what they showed here is a normalization of parathyroid hormone, which shows that the vitamin D supplementation actually worked, and they also showed an increase in the anti-inflammatory cytokine interleukin-10. They didn't identify any major clinical benefit from this, but nonetheless, they did show an increase in this anti-inflammatory cytokine interleukin-10. Giving these patients with heart failure 2,000 international units, I think, is absolutely inadequate, and these patients also received calcium, which would have been expected to block their magnesium absorption. So again, I don't think this study is consistent with good clinical practice, but I also think it's worth citing. At 2,000 international units, which is really too low, they did show an anti-inflammatory benefit by raising interleukin-10. So yes, we see some benefit here, but it's not consistent with modern clinical practice. So now let's take a look at this study. This was published in 2006, and again, they underdosed the intervention, and that's why we see kind of a wobble, so to speak, in their clinical results. This is from Journal of Nutrition, Health, and Aging in 2009. The intervention that they used was either 0, 400 international units, or 1,200 international units. All of those are too low. They showed a reduction in PTH, but inconsistent changes in C-reactive protein and fibrinogen. And again, when these patients were so deficient, you can see here, they started out horribly deficient, and with 400 international units, they were still very deficient at the end of the study, and even the patients who received 1,200 international units per day were still very deficient at the end of the study. So this study in no way represents modern clinical practice and supplementation with vitamin D. It may have been appropriate for its time, but I still think the doses were way too low for us to receive really good data from this study. The authors acknowledge that their power calculations were not originally made for markers of inflammation. They also state that fibrinogen was measured in a relatively small number of patients and that they needed a larger sample size to determine clinical and statistical significance. So again, I'm including this study for the sake of completeness, but it really doesn't provide us the quality of data that we need in order to inform modern clinical practice. Now let's look at a better study which was published in 2012. So remember, our entire view of vitamin D was changing during these earlier years. Let's say between 2000 and 2010, a lot of things were changing in the way that we perceived vitamin D and the doses that we were using. And I think that you see that represented in this study. So this was a double-blind, placebo-controlled intervention giving 1,000 international units per day to infants. And that's not optimal, but it's a reasonable dose for infants. After 12 weeks of intervention, vitamin D supplementation, again at 1,000 international units per day for these infants, caused a marked increase in their vitamin D level and interleukin-10 levels. Also, this resulted in decreased PTH, as we would expect, and a reduction in interleukin-6 and tumor necrosis factor alpha. Clinical benefits included significant improvement in the heart failure score, significant improvement in the left ventricular end diastolic diameter, also the end systolic diameter, the left ventricular ejection fraction percentage, and the myocardial performance index. So my summary of this study is that it shows amazing clinical and biochemical improvements in infants with heart failure who received 1,000 international units per day. They could have easily justified 2,000 international units per day per an article published in The Lancet in November 2001, and we'll take a look at that study in just a moment. So before we leave this study, let's just take a look very quickly at some of their parameters in the patients before intervention, after 6 weeks of intervention, and 12 weeks of intervention. You can see that their heart rate reduced from 154 to 130 to 124. The heart failure score reduced from 9 to 7 to 6. That's great. Ejection fraction percentage increased from 36 to 49 to 52. That's also quite good. Parathyroid hormone reduced from 40 to 32 to 28. 25-hydroxyvitamin D increased from 13 to 22 to 32, so they just about reached normalcy. Interleukin-10 levels increased from 1.25 to 1.65 to 1.85, while the interleukin-6 levels decreased from 30 to 19 to 16. Also a slight decrease in the TNF-alpha from 13.4 to 12.6 to 12.3. So again, overall, good biochemical and clinical benefits in this study. Title of this study is Impact of Vitamin D Supplementation on Markers of Inflammation in Adults with Cystic Fibrosis Hospitalized for a Pulmonary Exacerbation. This is from European Journal of Clinical Nutrition, 2012. They randomized 30 adults with cystic fibrosis who were hospitalized with a pulmonary exacerbation to receive either placebo or a bolus dose of 250,000 international units of vitamin D3. Remarkably, they showed a 50% reduction in tumor necrosis factor alpha and a trend for a 65% reduction in interleukin-6. They didn't measure any clinical parameters, but overall what they found is exactly what we would want. We would want a reduction in inflammatory cytokines, interleukin-6 and tumor necrosis factor alpha, also an increase in anti-inflammatory interleukin-10, and also an increase in the antimicrobial peptide LL37. So let's take a look at some of the details in their table number 1. As you can see here, interleukin-10 started at 42. 1 week later, it was 30. So their interleukin-10 went down. That's because these patients were acutely ill. So you would expect it to go down. The bolus dose of vitamin D wasn't effective at that time. But 12 weeks later, they may have seen some benefit from the vitamin D, at which point their interleukin-10 increased from 42 to 49. Likewise, tumor necrosis factor alpha reduced from 55 down to 27, so that's about 50% reduction. And also look at the antimicrobial peptide LL37, started at 73 and then increased to 142, so that's a doubling of their antimicrobial peptide production. So overall, I think this is a very positive study. Obviously, their utilization of 250,000 international units as a bolus dose is very suboptimal, so with a better supplementation program, I think the results would have been more positive and certainly more consistent with good modern clinical practice. Let's take a look at this study from Cytokine 2015. Supplemental vitamin D increases serum cytokines in those with initially low 25-hydroxyvitamin D levels, a randomized double-blind placebo-controlled study. So in this study of approximately 50 healthy adults, 46 healthy adults, they received either no vitamin D, 4,000 international units, or 8,000 international units. The benefit of the vitamin D supplementation was increased in interferon gamma levels and interleukin-10 levels. So this gives them more immune function, but also better anti-inflammatory modulation of that immune function. No clinical parameters were measured, and the summary is that supplemental vitamin D increased interferon gamma and interleukin-10 in subjects that were vitamin D deficient. We would expect this to translate to enhanced antiviral immune defense, coupled with enhanced control or modulation of that inflammatory response. And I think that we would all agree that that's exactly what we want. We want more antiviral defense, and we also want enhanced control or modulation of that inflammatory response. So now we're going to look at the effect of vitamin D administration on C-reactive protein and interleukin-6 in patients with ventilator-associated pneumonia. This was published in Journal of Critical Care, 2018. In this clinical trial, 46 adult patients suffering from ventilator-associated pneumonia and vitamin D deficiency were enrolled. The first group of patients received a single intramuscular injection of 300,000 international units. The other group received placebo. The inflammatory marker interleukin-6 was significantly reduced, and C-reactive protein levels also showed a trend toward improvement. The mortality rate among patients treated with vitamin D was significantly lower, so they showed biochemical improvement along with clinical improvement. So my summary is excellent